Evening, and thank you for tuning in. My name is Lee Smith, and I'm the current poll marker of the Brooklyn Long Island alumni chapter of Kappa Alpha Psi Fraternity Incorporated. Tonight, as part of our virtual fireside chat series, we bring you Real Talk, Beyond Birth, a workshop on holistic support for mothers and families. As we celebrate Maternal Health Week, we are in partnership this evening with the lovely ladies of the Eta Nu Sigma alumni chapter of Sigma Gamma Rho Sorority Incorporated. Our initiatives, Brothers for Mothers and Sigma Gamma Rho's Project Cradle Care, are solely designed to bring awareness to infant and early child care programming for the many families we support in the communities we serve. We have gathered a great panel of experts who will bring you an engaging conversation with the sole purpose to increase education and awareness around maternal health. So let's dive into this conversation and ensure our listeners get a head start on the support, programs, and resources available to them to raise healthy babies and build strong families. It gives me great pleasure to introduce your moderator for the evening, Kevin Boston Hill. Kevin?
Thank you, Lee, and good evening, everyone. Hello, and welcome once again to this latest installment of the virtual fireside chat Real Talk series brought to you by the Brooklyn Long Island alumni chapter of Kappa Alpha Psi Fraternity Incorporated and the Brothers for Mothers Initiative. My name is Kevin Boston Hill, and I will serve as your moderator for tonight's chat, Beyond Birth, a workshop on holistic support for mothers and families. Now, for this particular installment, we wanted to expand the reach of this very important message. Thus, we have partnered with the extraordinary Eta Nu Sigma alumni chapter of Sigma Gamma Rho Sorority Incorporated and Project Cradle Care. This week, April 11th to the 17th, is Black Maternal Health Week. This is an opportunity to shine a light on the systemic inequities and disparities in access to and delivery of healthcare services, especially in terms of pregnancy and childbirth. In New York, Black women are 5 times more likely to die from pregnancy-related causes than white women. To help provide education and awareness and potentially reduce those numbers, the New York State Department of Health has collaborated with several partners, such as the Maternal Mortality Review Board, established to examine information related to pregnancy-associated deaths and issue findings and recommendations to advance the prevention of maternal mortality. The Maternal Mortality and Morbidity Advisory Council, established to review the findings and recommendations of the MMRB to identify social determinants and other issues known to impact maternal health outcomes. The New York State Perinatal Quality Collaborative, initiated to engage a statewide network of birthing hospitals and centers that seek to provide the best, safest, and most equitable care for birthing people and infants in New York State. Now, add to these groups the recently signed law creating a doula directory and allocation of $4.5 million to support those regional perinatal centers, and it seems the road to maternal health care equality is headed in the right direction. However, according to our esteemed panel, which you will meet in a moment, more work has to be done. To help us understand how maternal health care impacts a large portion of our communities, we will welcome Dr. Allison David, a board-certified obstetrician gynecologist who is also the director of the OB/GYN simulation program and patient safety officer at North Shore University Hospital. Dr. David was recently nominated for Northwell's Truly Great Physician Award and recognized by her trainees for excellence in clinical care from the Society of Academic Specialists in General Obstetrics and Gynecology. She is also a proud member of the Eta Nu Sigma chapter of Sigma Gamma Rho Sorority Incorporated. Next, we have Dr. Larnie Booker, a board-certified general pediatrician with extensive experience in managing the physical and mental health care needs of children from birth to young adults and their parents. He is an assistant clinical professor of pediatrics at Rutgers Robert Wood Johnson Medical School and proud member of the New Brunswick alumni chapter of Kappa Alpha Psi Fraternity Incorporated. We also have with us Asiya Musin Franklin, a doctoral candidate in public health and certified nurse, midwife, doula trainer with over 19 years of experience in community and women's health initiatives, health prevention and promotion programs, health equity, and advocacy. She is also a proud member of the Eta Nu Sigma alumni chapter of Sigma Gamma Rho Sorority Incorporated. Next, we have Mr. Majesty Perkins, a licensed master social worker specializing in addiction counseling and crisis management. As the current counseling curriculum chair and adjunct professor at SUNY Westchester Community College, Mr. Perkins manages programs that assist students and clients with managing coping strategies. He is also a proud member of the Brooklyn, Long Island alumni chapter of Kappa Alpha Psi Fraternity Incorporated. And rounding out this August panel is Assemblyman Brian Cunningham, representing Brooklyn's District 43. Raised by a single Jamaican mother, he knows firsthand the struggles of working families in the city and the obstacles immigrants face on a daily basis, and was inspired to fight for social and economic justice for all members of the community. Now, I would like all of you watching to remind you that this event is being streamed on YouTube, and we encourage you, our viewers, to submit your questions to our panelists as well. Okay, as soon as Assemblyman Cunningham comes on, we will throw to him. But in the meantime, we'll begin right away with Dr. David and Dr. Booker. What are some of the obstacles that women of color face when trying to obtain the proper health care? And what are some questions that they should be asking their healthcare providers, not only for their child's health, but for theirs as well?
Hello, thank you for that question. It's a truly loaded question with many facets to it. I'd say honestly, the biggest goal of mine when I meet patients and women of color and any patient in general is advocacy. It's even knowing what questions to ask in terms of patient navigation. Where do I go? Who do I speak to? I think that's a large disparity within our community of just kind of access and knowing even where to go. A lot of my patients as an obstetrician come to my care later on in pregnancy. I found kind of the complete difference in terms of patients who are in more affluent neighborhoods. They may show up at 8 weeks, 10 weeks, versus my patients who are in non-affluent areas. They may not see me until potentially 15, 16, definitely into their second trimester. And a lot of that is potentially access, being able to take off of work, just life in general. And as the doctor that they're seeing most often, I have to be mindful of that, because even having to schedule the appointments frequently, potentially having to go and see specialists, getting to their appointments, it's not just about their health in terms of my blood pressure or my sugar level, because that's a whole nother story. It's just even getting you to see me that can sometimes be an obstacle within itself. So any patient that I meet, my first statement is, how can I be of assistance to you? How can I make this process of being pregnant, of just having, potentially needing gynecologic care, abdominal pain? How can I help you get to where you need to be? Because I feel like that's one of the biggest things that I find is the hardest to manage, just having access, having a gatekeeper, having social work, having, access to getting a ride. I think though that's kind of one of the biggest things that I've noticed that we need to address.
Yeah, good evening. The thing that I would say is on the provider side, the thing that I'm always trying to build with patients is trust. And so first, I want to know what their concerns are, what their fears are, and be sure that they understand that I hear them. While in this era of a lot of information being available, sometimes information is received, it's not received in the way that's intended, or the fears that someone has may be out of context to the symptomatology that they're having. However, your fears are real, your concerns are real. And so the first thing I want to know is what you're most concerned about, because then as a physician, I can address that problem and be aware of that problem throughout the course of your pregnancy or throughout the course of your care. For me as a pediatrician, it's throughout the course of the care with your child. So if I know walking in that you have this concern, I can immediately walk in and say, hey, I know per our last visit, we had this conversation, you were concerned about this. Well, I still don't see any evidence of a problem in that given area. I always want to know what their history is. So from a pregnancy standpoint, what their pregnancy history is, because that gives me some window into understanding what I should be looking for their current child, but also what their family history is, and so what they've been, what other experiences or exposures that they've had. And so those things allow me to kind of shape care and build a relationship, because the most important thing we get is trust. And if patients trust you, they're more willing to come back to you. They're more willing to, and sometimes it's not even coming back, it's just calling. Sometimes they have a concern, and instead of Googling it or looking up, they call your office and leave you a message. And you get the ability to say, hey, no, that's a real problem. That one, I need to see you, and I need to see you immediately. Or you can call them back and then reassure them. So, I think that there's a lot of different aspects to healthcare that create their own problems. Access to care, time and schedule, the ability to take time off, as Dr. David mentioned. But once they're in our space, I think our biggest thing we can do is make sure that we listen, directly address their concerns, read facial expressions. Sometimes it's in people of color, in terms of us taking care of one another, sometimes you can answer a question that they haven't even asked you yet, because you can read their body language, you can read their facial expression. We know from our own culture, different stereotypes or mindsets, and you can address those early on, and sometimes you receive it, and people feel, again, more comfortable when they realize, oh, they know exactly what angle I'm coming at this from, or they know why I feel that way. And it'll give them that sense of comfort. But again, that idea that the true idea that we really care, and that we're trying to manage them and manage their families and their well-being as best we can.
Now, Dr. David, I'm going to follow up with you really quickly, because you mentioned that a lot of your patients don't come to see you for the first time until they're well into their second trimester. So for some of the listeners who are out there who may be those mothers to be or families to be or so forth, when should they make those first appointments to go and see their obstetrician or gynecologist to start talking about how to really, as far as all the prenatal steps they should be taking? When should they make those first appointments?
So when it comes to preconception, that's separate. Then there's prenatal, and then there's postpartum. So my patients who are seeing me for gynecologic care, meaning their regular annual checkups, if you have a medical history significant for a potential pregnancy problem in the past, high blood pressure, diabetes, I may send you to preconception counseling. So that would be someone who can go over your history, talk to you about what to expect for pregnancy, things that we may want to optimize or you can do to help you get pregnant and have a safer pregnancy. That can be done at any point. Once you actually get pregnant, then we start talking about the first, the second, and third trimester. We have different intervals for each trimester. So typically, I'd like for you to start prenatal care around 7 to 8 weeks. Generally around that, because we start and we can actually start doing some, we call them NIPS. Basically, it's non-invasive prenatal screening. It's blood work. And we can do it for you as the mother. We can do that for you through your blood work. So we can actually tell, one, fetal gender, but more importantly, any genetic abnormality. But you need to be at least 9 weeks at the minimum, so that we can have enough of fetal placental tissue in your system to be able to test that. And it's not bothering in terms of being invasive to the pregnancy, it's just taking your blood, but you have to be at least 9 weeks for that. Then once we get to that point, then we see you around 12 weeks, then we see you around 16 weeks, then we see you around 20 weeks, 24 weeks, 28 weeks. So as time goes on, you will get kind of these 6 weeks, 4 weeks, then 2 weeks. But our very first visit, I like for it to be around 7 to 8 weeks, because at that time you can actually talk to me. We can meet one another and say, hey, I'm going to be your doctor. And then depending upon the group that you join, we can have a conversation about what to expect when it comes time to deliver. Because if you have a private practice doctor where that's their solo practitioner, so they're the only one, they're answering you, they're delivering you. That's how their practice works. If you're in a group practice, then you need to know that there are potentially 5 or 6 people who are working because they have to spread the call. But if you don't know that, and then you come into the hospital and you have an issue, or you call us on the phone and you're like, I don't know who you are, I didn't even know this is how this worked, then there lies back to Dr. Booker's point of the trust component, because we didn't have that conversation. So now you're caught off guard. So a lot of the earlier visits I use for expectations. I use to answer questions about how you can contact us, things that you should contact us for, important places, going over the hospital, going over how that works to get there. My hospital is in Manhasset, so it's at 300 Community Drive. So it's the rule of the threes. So I tell them the rule of the threes. If there's no 3 involved, you're at the wrong place. But that's the time to kind of have those conversations, not when they're, concerned about a million other things, because now we've got to get the basics out of the way, because now we got to go over what to expect for pregnancy. So I usually like to do it early so we can get the groundwork laid and you can meet me. And then at the next visit, you will potentially meet my other partners.
Gotcha. Thank you. And Dr. Booker, I'm going to follow up with you as well, because you talked about that building that trust. So and you talked about from the doctor's perspective, but also how can that be done from the family's perspective? What support can the spouse or partner of the mother be able to provide to also build some of that trust?
Yeah, so on my end, the first thing I don't see the patients until the baby's born. And so I may see them in the hospital, postpartum, as Dr. David mentioned, or I may see them in the office once they've been discharged from the hospital. And so, I think for spouses, I think there are different challenges. So one, mom is delivered and she's just going through the physical discomfort of having delivered, whether it's a vaginal delivery or a C-section. If it's a C-section, it's major surgery. So there's a prolonged recovery course. And so I try to express to spouses, hey, I say to moms in the hospital, take off your Superwoman cape. You've done the hardest part of this. You carried the baby, you've delivered the baby. Now you need to actually rest. You don't need to be up trying to figure out how you're going to paint stuff and wash every dish or rearrange the kitchen, or like all that stuff needs to go on the back burner. It's a great time to allow your family to come in and be supportive. During COVID, one of the biggest problems we had is that people were having babies alone. It was just them and their spouse. They didn't have this ability to have their village be around them. And that support is really, really important. It's important because people want to love on your kid. And that first interaction with that new family member is really special. It really does imprint on people and build a relationship that they're looking to, further through that child's life. So this is the time where you need to have if you trust your family, and you like them, you want your parents around, you want your brothers and sisters around. From the baby's health standpoint, we look at it as, hey, just try to keep people who are sick away from the child because you don't want the baby to get sick. But it's a really important time for spouses to kind of take on the extra, just ensure the comfort of the household, mom and child. If there's other children in the household, it can be a bit chaotic. And again, that's why you need that additional support to give everybody a chance to kind of focus on the new child that's home. As moms who are breastfeeding is hard. It's not always a simple thing of just the baby comes, they attach the baby latches and the baby feeds well. Sometimes there's some struggle there. So again, it's being there to support, making sure that mom's comfortable. If she has the boppy pillow or whatever assistance she needs in terms of positioning, making sure that if the mom needs the breast pump, being sure that the spouse has the pump is clean, everything's set up. So mom doesn't have to do quite as much, to kind of get things started. So any support that they can offer, especially that overnight support. Newborns typically are awake at night because they're used to being more active when mom is at rest. So when they first come home from the hospital, they're really active in the overnight time frame. So again, having the support to be able to say, hey, dad or significant other, go get the baby for mom when she's getting ready to nurse. Again, making sure that everything's up, get up, change the diaper, bring the baby to mom, so mom is not trying to do all that again as she's recovering from the birthing procedure.
And that response is the perfect segue to Ms. Moosen Franklin, because what I want to ask you is, along those same lines, from your perspective as being a doula midwife, what should new or expectant parents, including those fathers and partners, do to help prepare the household for the new arrival? And part two of that is, what else can they do to support the mother through pregnancy, birth, including breastfeeding?
That's a great question. I'm glad you asked it. I was actually sitting here thinking of, I wonder if he's going to ask that question. So as a midwife and a doula trainer, one of the things that I focus on is care of the birthing person. When a new baby arrives, we always want to dote on that baby. We want to love on the baby. We want to pour into that baby. And sometimes the mom or the birthing person kind of gets tossed to the side. Their needs are not met. How long has it been since they've showered? How long has it been since they've had a cooked meal? Are they making it to their postpartum appointments? Because that's equally as important as their prenatal appointments. Are they eating warm food? Do they have what we call in the midwifery space a lying in period, where the family is coming in to care for them and they can rest as they need without having to go back to work right away or care for the baby 24 hours and they're running on fumes? So the thing that spouses and communities can do for women and birthing individuals in the immediate and even the longer postpartum period is find out what they need and give them what they need. Don't assume that you know what they need. Ask them, what do you need from me right now? And when they tell you, I need a nap, or I just want to go and take a shower, or I have to go to my visit, or I'd like some soup, one of my favorite things to eat when I'm not feeling well or when I'm healing. When they tell you what they need, give them what they're asking for.
Thank you for that. Thank you for that. And I guess because that also ties into somewhat of the mental health of the mother as well. Because again, when most of our family members come over, they come over to see the baby, and like you said, they dote on the baby and they kind of ignore the mother. So what type of impact might that have on the mental health of the mother?
Well, I think everybody on this panel can attest to the rising rate of postpartum depressive disorders. A lot of that is because so many of us in our community, one, don't have support, or as Dr. Booker shared, don't like our family, don't have relationships with family members, so we're out here just alone. Coupled with the drastic change in hormone levels after you've birthed, all of those things contribute to the rising rates of postpartum mental health disorders that we are seeing. I always recommend and I always provide a list of mental health practitioners and providers in the area, whether they've asked for it or not. I let them know what the symptoms are, when it's just baby blues, and when it's a psychosis, or when it's something that's depressive or really serious that needs to be addressed, that cannot be handled at home through, and I might ruffle some feathers when I say this, but can't be handled at home through prayer alone, that we need to add what we've been gifted with, what we know through science and what we know through medicine and through studying mental health and the human brain to adjust and aid them with adjusting during that period of time.
Yeah, thank you. Thank you. And Mr. Perkins, don't think that we've forgotten about you. We know that you're there as well. And I'm sure that type of a question would have been perfect for you. And I'm going to hold off on you answering the mental health aspect for a moment, because I want you to really address what are some of the other resources and initiatives that families can turn to for support?
Hello. So just to clarify the question, you want to talk about some resources?
Correct.
So there are several different resources out there. I think that one thing that is extremely important for us to know, especially living in New York City, is that the resources are available and they are all over the city. And we just have to know how to find them and know how to find them because the access is there, right?
Now, I know you said, and sorry to cut you off, but I know you sent in some slides that you may want to go
Absolutely.
over. You want to go over them now?
I mean, I can speak to them.
Okay.
Yeah,
So
so
I will get your resources in front of you right
oh, not
now.
an issue. So there are several different resources that I would suggest. There are resources from the city, from the state, from non-for-profits. 988 is a great resource. Mental health for all is another great resource. Mental health for all is a central hub where every New Yorker can connect to care and find mental health resources for themselves and for their loved ones. All you have to do is pop onto the site. You'll be able to put your zip code in, your ethnicity, your gender, and they'll be able to really hook you up with what you need. I think that it's also important to note that this is not necessarily one size fits all service for any of them, right? Something could work for your friend, but it won't necessarily work for you. So it's important to know that. And it's important to also be patient in the process. The first service or the first thing may not be exactly what you're looking for. So, it is a little bit like shopping around, right? We have HITE, which is the Health Information Tools for Empowerment. This is a resource for medical, mental health, and related services in New York. And this is specifically popular with anybody suffering from postpartum to needing parental support to they even do other things such as LGBTQ services, to mentoring, to psychological testing. I think that one thing that we really know is that when the family is suffering, or when the caregiver is suffering, when the mom and the mother is suffering, the child is also suffering too at that moment. So I'll end there. I don't want to take up too much time, but I have more resources as
No,
well to share.
that's quite all right. That's quite all right. So I'll pause us there and come back to you in a moment because we actually have the assemblyman has joined us. So I wanted to give him a moment to be able to talk about some of his experiences as well. So Assemblyman Cunningham, thank you for joining us for this very special conversation.
Thank you so much, Kevin. Really appreciate it. And thank you for hosting it.
Oh, it's my pleasure. It's my pleasure. So I guess, and I know your time with us is limited, so I'm just going to go right into it. I guess, in your opinion, what is the biggest challenge facing expectant families in urban centers?
I think the biggest challenge is the lack of care in communities of color, particularly urban communities. I think about my own experience with my wife and I. My wife and I did not know prior to 2018 that she suffered with this thing called endometriosis, fibroids, and cysts. And she'd gone to her doctor every year, gone to OBGYN, and the care was kind of dismissed as, keep trying. That was kind of what they told us. Not knowing that we had, tennis balls growing inside of her in terms of cysts. Luckily, it was around 2018 that we really started having a conversation around family planning and what that meant for both of us. And through that process and being able to have obviously insurance and seeing some good doctors, we would identify some of the challenges we're facing and create some plans around it. We are proud of our son, Senator, who is 4 months old, going to be 5 months this week. He is an IVF baby, right? And, access to care, particularly close to your neighborhood, access to health insurance, and also just telling your story, I think is really important because I think as we began to become more open about the challenges we're experiencing, we were able to, one, identify other moms and birthing people who were also going through similar things, be able to give us some advice. So I think those are some of the biggest challenges, access to care and obviously neighborhoods that are losing hospitals significantly. This is quite frankly a bipartisan issue. It's an issue affecting Black women specifically. Everything, systematic racism affects Black women at higher levels. When you travel to suburban America, when you travel to rural America, some of these issues are also there as well. And for Black folks in rural parts of the state and suburban parts of the state, it's exacerbated 10 times more. So definitely have to make sure that we're providing this information. So again, a conversation like tonight is so critical and so important.
So let me follow up with that a little bit and ask you, how has Governor Hochul's new proposal to provide prenatal time off, how has that helped Black mothers receive some of the resources that they need?
I think obviously, access to care. A lot of moms and families and parents in general, birthing people are taking time off of work to go to a doctor's appointment. And obviously, if you miss some of these appointments, you miss some of the early signs of things that are affecting mom and things that are affecting the potential baby. So anytime you create access and, create that time off for people, be able to take care of that. I think that's critical. We were very fortunate again. My wife is an entrepreneur. She runs her own organization. She was able to take that time off as she needed and work her schedule around it. Obviously, outside of working for the people in Albany, I was able to also carve out some time in my schedule to be there for all those appointments and ask the right questions and to make sure we had follow-up care on the things that we didn't understand. So I think it's a significant proposal. I applaud the governor on identifying this being an issue and actually putting some teeth into it. Obviously, we have a long way to go in terms of access and equality and making sure that every parent across the state has the same access that I have and that other folks do as well.
Now, I know you're in the middle of doing the important work for your district, but if I may ask you one final question before you do have to run back into your session, um, just how important are sessions like these, like we're doing tonight, these sessions in highlighting awareness of maternal health disparity issues, and how can organizations such as fraternities and sororities partner with offices like yours in order to enact some of the change?
Yeah, I mean, before, again, I'll say it again, but before 2018, I had no idea I was enlisted in this fight for Black mothers and for Black birthing people. But obviously, personal circumstances have hit my door. When I first got to Albany, I thought my fights would look very differently. But because of my experiences, I bring those lived experiences into conference, into session, into every conversation. I think any opportunity that we have an opportunity to echo things that start as a whisper but become a crescendo in these halls is really important. And I think organizations like yours play a critical role in getting information out to the masses. There are 14,000 bills introduced in this body every single year. A lot of those bills don't see the light of day. A lot of those bills don't get amplified because people just don't know about them. So I think any opportunity to spread information, particularly around an issue where you literally had my wife's entire pregnancy, my biggest fear was my wife going to be alive after the pregnancy, right? And that shouldn't be a thought that you have when you're expecting life, that death may be on the other side of it, or is something going to happen to my child in the midst of trying to give birth to the child. So I think, obviously this is just an opportunity again to continue to enlighten people that these disparities exist in our healthcare system, that these things happen 10 times more with women of color, specifically Black women. We have to raise those alarms, and I think organizations like yours are in a good spot to get that information out to the masses and also be able to champion and put pressure on people like myself who hold elected office to get things done on this issue.
Thank you. Thank you. Like I said, I know you do have to run to get back into session
Back to the budget. Yeah, we're in the
doing
budget
the work.
conference. So I'm in my comfortable clothes. We're gonna be here all night until we figure this out. But thank you again so much for creating space for us to have this conversation. I look forward to our office partner with you on future events and making sure that we get the word out and obviously help to create some legislation that's going to save countless lives of women and children across the state.
Thank you. Thank you. And we look forward to working with you as well. And
Thank
I hate to say it, but have fun in dealing with those budgets.
I will. All the numbers.
have
All
a
right.
great
Love you,
evening.
sir. Bye.
Now, Mr. Perkins or Brother Perkins, I actually want to come back to you for a moment because the Assemblyman talked about one of the, I guess, the darker sides of pregnancy and the things that can possibly happen and that we don't want to mention. And that's either the mother and or the child dies during the pregnancy or during the birth. So can you share with us some of the coping strategies and that families and can go through when if they are faced with such a tragic event?
I mean, absolutely. First and foremost, I would definitely, recommend that their family and that their loved ones really rally around them, right? Whatever friends that they have nearby, their entire support network, because they're going to need it. Thereafter, I would definitely recommend grief counseling, because that is extremely important. right? Making sure that their needs are attended to. I think so often we lose someone, we lose a child, or there's a miscarriage, and we take for granted the effect that it actually does have on our body, right? And we know that the body does keep score, and the body is connected with the mind. So it's extremely important for these mothers and families to get the support services that they need. Listed here, I have one thing I never want is to have a workshop and people leave with nothing. So we're gonna send this out to everybody who clicks in tonight. And these resources are here. The bereavement support specialist, the guidance from the Calvary Hospital, they do an amazing job with all types of grief counseling. And I definitely would recommend them for anybody struggling with any type of loss.
And if you want to go through the rest of the services and resources that you have in front of you.
Oh, absolutely. I think that, supporting mothers and families as a social worker is also supporting the healthy development for our children, for our youth in New York City, especially especially families within low-income communities. The first few years of life are an incredible window, an incredible opportunity for brain development. We know that those first few years of life are the foundation for children's future learning, their social skills, and ultimately their overall well-being, right? How they're gonna, like, the trajectory of their life depends so much on those first few years. So mothers and families really need to be supported with the right tools and resources so that they can raise a healthy child, but also make sure that their entire family is taken care, but also to make sure that they are taken care of in the process as well. I have a bunch of sources listed here. In terms of going back on the other page, the ACS prevention services. So oftentimes we know that seeking help always comes with negative connotations within our Black and Brown community. But ACS is not always just taking the child away. They also do a ton to help as well. So these are all links in terms of like if you click on prevention service, that's the link. The prevention provider directory, that's a link. And the ACS Connect Me, that is also a link with all different types of services, depending on the need for their family and depending where they are in their borough, right? And these are preventative services. So it doesn't mean that ACS is gonna come take your child away or hound or bother the family. They're just there to support. And in fact, it's not even an ACS worker. When you click on the prevention provider directory, it's actually a list of nonprofit organizations, right? Some who have been serving New York City for hundreds of years. So I would definitely recommend going in there, depending on what the issue is, whether it's mental health, domestic violence. I've worked with many mothers who have, they use negative coping mechanisms such as turning to a drug or alcohol or something like that. So anything substance abuse or special medical needs, right? That list is beautiful for that. And then these are some other nonprofit organizations that you also pulled up on the screen as well that I would urge families to check out.
And I'm glad that you posted those resources from ACS because everybody who has heard of ACS in New York thinks of it from a negative standpoint, negative connotation, that they're just coming in to take the children out of the household or something like that. And they don't really know about all of the preventive services that they are responsible for and that they actually want people to come in for. They rather deal with the prevention so that they don't have to come in later on as a last resort to remove children out of the household, because they want healthy and thriving families to stay together as opposed to breaking them apart.
Exactly. And I completely agree with you. And over the last 2 years, ACS has done a lot of work. They're like no organization. They're not perfect, but over the last 2 years, they've done a lot of work in transitioning their organization to become more preventative, right? So when those ACS calls are made, they don't necessarily take every case. They'll say, hey, maybe check out this preventative service as well. So that's extremely important for our families to know.
Now, this next question is really for any and all of you to chime in, and you can respond to each other, build off of each other's answers, or however you want to answer it. But I want to know from you all, the experts here, what are some of the, I guess, the long-term mental health and physical health effects on the mother and child of inadequate or disproportionate maternal health care? And anybody can start.
I guess I'll kick that one off. As I'm thinking about that question, I'm actually thinking a lot about the physical health in terms of long term. So our patients that look like me, of color, we tend to have high blood pressure. We tend to have diabetes. We tend to have preeclampsia, which is high blood pressure in pregnancy, with the addition of protein in our urine that may have not been there before. We even have potentially increased risk of cardiac issues. And we're finding that our mothers who have these issues in the pregnancies, such as preeclampsia, severe preeclampsia, things of that hypertensive disorder family, you tend to later in life develop high blood pressure. You tend to develop cardiac disease. You tend to develop all these things that pregnancy is a small window over your potential lifespan, but can be an indicator of what's to potential to come. So my goal for my pregnant patients, when we start to, see blood pressure issues, diabetes in the pregnancy, is to kind of get ahead of it and get on top of it if we see it early enough. Sometimes we don't diagnose preeclampsia until the very end. And a lot of people say, oh, I had preeclampsia, that's why I got delivered, because that's the answer. And then in our hospital system, we will refer you to what's called cardio OB, which is a cardiology practice specific to our obstetrical patients. And they continue to follow them because we know that there is this risk where pregnancy can be a window or a precursor to what's to come. Now, even to that effect, in hospitals that I've worked at prior to where I'm at now, there wasn't necessarily a cardio OB team. There wasn't a group of people designated to our pregnant and postpartum patients who are solely and specifically designed for that purpose. So even being able to have access to that particular group can potentially set you apart to help you later in life, to know, these are the warning signs, to keep your blood pressure down, to take medication if necessary, because it doesn't mean you have to forever. Changing your diet, changing your activity level, just having that information from the time of being pregnant and the early postpartum period can absolutely help you later in life. And as it was stated before, when the caregiver is not okay, the family's not okay. So that's an absolute direct effect on your children later and the line within your entire family, because the kind of maternal background is the backbone of your family. And when we're not okay, the family's not okay.
Now, before the rest of you chime into that question, I do want to remind our viewers out there that you can use the chat feature or the comment area in YouTube or Facebook to put in your own questions if you have any questions for our esteemed panelists. So again, continue. Anybody can pick up. Dr. Booker?
Yeah. So, I would say that from the child standpoint, mom is the vessel by which this child is going to develop. And so mom's nutrition, mom's physical health, mom's mental health are all going to have a strong impact on the success of the pregnancy and the health of the baby that's delivered. In cases where mom is affected by things like diabetes, so diabetes, maternal, gestational diabetes, or diabetes overall that includes pregnancy, can lead to cardiovascular complications in the baby. It can also be used to cause the baby to be really large because of the excess blood sugar that mom has. And so those kids tend to have issues with their blood sugars once it's delivered. So they need to be monitored very closely. For women with hypertensive conditions Well, with high blood pressure, sometimes it reduces the amount of blood flow to the placenta. It reduces the oxygen to the placenta. It reduces the nutrients that are transmitted to the placenta. Therefore, those things are reduced to the baby. So in those instances, you have babies who have intrauterine growth retardation or slow growth. They're small at growth. And so they may run into some complications, right after delivery, or they may present smaller or not as healthy as you would expect them to be. The good news on that side is that these are all conditions that we can be aware of, being aware of what the maternal health is going in to the delivery portion of the pregnancy. And so those are the risk factors that we watch very closely in the immediate postpartum phase, and can address immediately in the hospital. But as was mentioned earlier, if mom's not well, I say to moms, you are the sun. You don't realize it in your home, but you're the sun. Everything in your house rotates around you. And so in a healthy household, if you're not well, your kids aren't well, because they perceive your stress, they absorb your stress. If you're not well, your spouse isn't well, because they're trying to ideally fix the situation and bring calm and peace to the home. And so it's really important for our mothers and our birthing persons to just be in as good a health as possible. Sometimes the pre-existing health conditions are going to make the pregnancy more difficult or more complicated for Dr. David and other obstetricians or high-risk OBGYNs. So we look at it like it's not a matter of just health going into while pregnant, but it's health overall going into pregnancy. Healthy mothers generally deliver healthy babies, but it gives your obstetrician the best opportunity to have as few problems going in as they can, and then again address problems as they occur.
I also think it's important to note both Dr. Booker and Dr. David shared some phenomenal information. But I also think it's important to note that mother-baby bonding is something that's not talked about often, and that has long-term effects, not just on the mother or the birthing person, but also on the infant and child development of the baby that they've given birth to. So that time could be disrupted by preterm birth. It could be disrupted by a NICU stay. It could be disrupted by not being able to breastfeed if that is the desire, or not having the support to breastfeed. So ending breastfeeding earlier than expected. If there are comorbidities such as hypertension and gestational diabetes, that also impacts the mother's health. If the mother passes away, if there is a maternal death, that of course is going to impact the long-term health and well-being of that infant. And just recently, the New York City Department of Health has shared that about 66% of maternal deaths among Black women are preventable. So we have our moms and birthing people out here dying from preventable health issues. And a lot of that is because they're not receiving the proper care. I always come with the 3 A's: alignment, advocacy, and access, right? If you are high risk, a midwife who primarily focuses on out-of-hospital births is not the person that you should be coming to see. You should be seeing Dr. David, and she's probably going to refer you to a maternal health specialist. That's the alignment that a lot of people in our community are missing. Well, I want to have an out-of-hospital birth, or my first baby was born by a midwife, and I want to have a midwife again. But you are preeclamptic, you have gestational diabetes, you may have had a previous cesarean section. All of those things rule you out from receiving care from me. So there's no alignment. And Dr. David also spoke about access, and then advocacy, being able to advocate for what you need. Not everyone has the level of health literacy that we have here on this panel, but speaking to our patients and to those in our care at a level that they can understand, and asking them to give it back to us. Do you understand? What did I say? Any questions? Making sure that they are walking away with all of the information they need so they can make informed decisions, so that we can see less and less of the long-term effects that are plaguing our community now.
Brother Perkins, would you like to chime in on this one as well?
Yeah, absolutely. I think that we kind of spoke to it a little bit, but remember just the postnatal depression for the mom, what that looks like. We're talking about mood swings, appetite, not being able to eat, could even be self-harming, right? Transition those things onto how they actually look for the kid, for the child. Now we're actually now where we're seeing the child start to develop attachment issues, which as you spoke about, Sia, that's healthy bonding that the child needs. When the child doesn't get that, now we start to see feelings of insecurity, anxiety, difficulty forming relationships later on in life. That's extremely important. That's going to lead to emotional dysregulation, right? Where infants and young people, they need their caregivers to help them regulate their emotions. Without that nurturing care, which we know from research, children are going to struggle to manage their emotions there. It's going to lead them to frustration. You'll see heightened periods of anger, and you're going to have like their school, those they come in contact with, they're going to have extreme issues calming them down, right? As we go later on in life, we start to see a pattern, we start to see a connection between what attachment issues look like, with what emotional dysregulation look like, and one's own development of low self-esteem. So all these things are really connected in terms of mental health.
And we do have a couple of questions from our audience. And this question I'm actually going to direct towards you, Ms. Franklin, and because it's a breastfeeding question. The question is it true that breastfeeding for as long as possible helps with the health of the mother and the child's immune system?
So as long as possible is very broad. I will give you the science behind it before answering that question. Worldwide, so the World Health Organization has shared that worldwide, the average amount of time for breastfeeding is 2 years. In the United States, it's about 6 months. And for Black women, it's somewhere between 6 and 8 weeks on average. Now, of course, there are outliers, but these are averages. Breastfeeding absolutely is beneficial for the baby's immunity, their growth, bonding with the birthing person, the mother. But for the mother, there are also benefits. It reduces chances of breast cancer, of developing breast cancer. It helps with reducing the size of the uterus and returning it to its non-pregnant state. It helps with balancing hormones. So yes, there are several benefits to breastfeeding. The challenges with breastfeeding outside of the physical challenges, because breastfeeding is difficult. Some babies latch beautifully and others struggle. It can also be painful for some individuals who are breastfeeding. The challenge within our community, and when I say our community, I'm speaking about Black people residing in the United States, whether they're African American or of any other African descent, is not having time, having to return to work so quickly that they cannot breastfeed, meaning putting the baby to breast, and they might resort to pumping. And while you can still get substantial amounts of breast milk through pumping, sometimes the supply is not there, which becomes a challenge and leads to the cessation of breastfeeding. So 2 years, I don't know anyone personally who has succeeded in breastfeeding, any Black women who have succeeded in breastfeeding for 2 years. 20 months is where we're at right now. But yes, abounding benefits for the mom and for the baby.
Now, I don't know if you can co-sign on what I'm about to ask you, but I've heard that from a previous workshop that we've done, I've heard that there's actually a Black market for breast milk.
Yes, and I will not go down that rabbit hole tonight, but what I will say is there's a Black market for everything, including breast milk. Now, I am an adoptive parent, and I used donor breast milk in addition to inducing lactation to breastfeed my 2 youngest children. The donor breast milk came from my best friend who had a clean bill of health. We lived not too far from each other. I knew her health history. I knew what she was doing with her life, how she was spending her time, that she was substance free. Those situations, because that has been my experience, I can advocate for. But black market breast milk, where you just go into a Facebook group, let's say, and you're like, hey, I need some breast milk. And Susie down the street is like, I'll meet you at Walmart and I'll give you some frozen breast milk that I have in my freezer. And you take it and you start giving it to your baby. Not okay. I do not recommend it. I think the people that go that route are so desperate to breastfeed because they feel like that is the only way that they can experience birth and pregnancy and being a new mother, being a new birthing parent. But having a child is what makes you a parent and what makes you a mother, not your ability to breastfeed. So if it is a challenge, there are breast milk banks that test the milk to make sure that it is clean and it is safe for your infant's consumption. If you are dead set on giving your baby breast milk and you cannot produce it, and you don't have a close friend who you know her breast milk or their breast milk is safe, then I recommend going through a milk bank, not just going on social media and asking someone for their breast milk.
Thank you for that important clarification. Dr. Booker, Brother Booker, I'm going to actually come to you for this one because I know you are a pediatrician and you probably have seen this situation before. And the question from our audience is, and Dr. David, I'm going to ask you to chime in if you can when he's done. Is there any correlation between autism and maternal health as it relates to the environmental exposure?
So to this point, the autism is a really challenging thing because it's a multifactorial problem. And there's not been one specific thing that has been identified to say, hey, this is what puts you at a greater risk, or these causative things in terms of whether it be maternal health or otherwise, that seem to be an immediate link. So I would say that there's not something that's specific in terms of maternal health. I think that what we have in terms of autism overall is that autism has a changing definition the same way that asthma has a changing definition. So for many people, you grew up and nobody around you had asthma. And then all of a sudden you look now and a lot of kids have inhalers or nebulizer machines. And what's really happened is we've changed the definition of what we call asthma and how we identify it. Because now you can recognize much more milder symptoms that would otherwise have been ignored, but however created longer term health issues. And for autism, the autistic spectrum is a much wider. So if you are familiar with movies like Rain Man, that character would be considered a person a generation ago that was considered autistic, and they had to meet significant criteria in order to reach that diagnosis. Whereas you have the spectrum where you have kids who are autistic, but they're mild or they're what we call high functioning. And then you have kids who are more lower functioning. So from a maternal health standpoint, there's not been a clear identifier that we have to this point to recognize or say that a child at increased risk for autism. Clearly, substance abuse affects the brain overall. No maternal health care or poor maternal or paternal prenatal health care can have deleterious effects. But to say that they're specifically linked would be inaccurate.
Okay, thank you for that. Dr. David?
I would agree with Dr. Booker when it comes to that. It's hard to nail something down in a mom's history that can give us an idea. But I think overall, to the point of just your overall health is what we need to focus on, because unfortunately we're not able to determine that if you don't do this, your baby will not have autism. We don't have that information. But the things that we do have information about, are just your overall, your blood pressure, your weight, your kind of outside exposures, decreasing your exposure to, cigarette smoke, secondhand smoking yourself. Just kind of those things are things that we absolutely can talk about in terms of changes of lifestyle. But as far as something that we can nail down on doing that you will not have this issue, we don't have that information.
Okay. Thank you. Thank you. But while you are here responding, I actually want to address this question towards you and also you, Ms. Franklin. And that's, in your experiences, in your professions, are you witnessing any increase in comorbidities in younger or teenage mothers, expectant moms? Or is that more as from an older or mature expecting mothers? Which group has the higher morbidity rate?
Wow, that's a very insightful question. I've actually never had that question from anyone before. The honest truth, our patients are actually waiting to have children. So a lot of times, just with age comes their own set of complications in terms of pregnancy. So yes, when you're older, you do have the propensity to have medical comorbidities that can make a pregnancy complicated. So within that aspect, I'm seeing it more because our patients are actually older to begin with having their first child, which is not what it used to be when I was, a young girl. Most of the time, your first time moms or your moms in general are maybe in their 20s and 30s, and that's kind of it, and even their teens. Now we're getting moms who are, in their 40s and 50s. So it's just by the sheer number of patients that are just older. But as far as when you're younger, have I seen an uptick in their overall health problems? I wouldn't say a strong no, but I do find that it's important for young people, boys and girls, that they need to have active lifestyles, because I'm finding that they're heavier. We're not, even when I was a kid, I'm running outside and I'm not coming back in the house until it's, I'm drinking out of the faucet outside, and I'm not back in the house till the lights come on outside. Children aren't doing that now. So, you have the chance to gain, more weight. We're eating a lot more fast food, just in general, as far as just our overall lifestyles. So are my patients who are younger having medical issues that they didn't have previously and my older colleagues weren't seeing? Yes. But they are preventable things that we can kind of deal with, that they won't have the issues when they get older, but we've got to catch it, when they're younger.
Thank you. Ms. Franklin?
Well, I will say I'm not well versed in this area. I do not work with teens or very young birthing people and women, simply because it's not considered low risk. And midwives, we focus explicitly on low risk pregnancy and birth. So someone who is extremely young because of age would not be a good fit for midwifery care. So I don't really have a direct answer to that question.
No, that answer was actually perfect, because I'm sure are some people who may be considering a midwife or a doula, and they may be a little young, not realizing that because of the young age, that kind of disqualifies them, if that's such a term to use here, disqualifies them from those particular services. So that answer actually works out perfectly. Thank you.
Absolutely.
Brother Perkins, I want to come to you for a moment with this question, and I think we may have touched on it a little bit throughout the course of the evening, but in your estimation, in your expertise, what should be the role of fathers in the overall process of birthing, and how can they be of better support, not just physically, but also mentally, to their partners?
I mean, Brother Boston Hill. Good question. Loaded question, all right? Could take a very long time to answer, but I'll try to keep it brief. I think that fathers have a very important role in the maternal process. I think that, not even just I think research shows that when fathers are there every step of the process, it takes stress off of mom, right? And all of the overall outcomes are much better off, in terms of the pregnancy is successful, the baby is more healthy, the mom is more healthy. Fathers need to take an active role, right? Again, being there every step of the way. You're helping mom off her feet. You're starting to help out cook meals. You're making sure she's accompanied to appointments. Like, I think that is the role, right? And then once the baby is born, also making sure that you're not leaving all of the tasks to mom. I think, with certain agencies, even in New York City today, mothers are only given six weeks off, right? Fathers can be given about the same. So I think that the time crunch is difficult. Some things that I often recommend, even for families, is to sit down together and actually make a strategic plan, right? I always recommend, mom, take your time, and if you can take more time, take that too. All right, dad, you, in most agencies, you can take 2 days here, come in 2 days here, right? So that the support is kind of balanced in that way. Because that support is extremely important, because the time frame for mom to develop severe postpartum depression is about 8 months to a year after they give birth. And that's an extremely important time frame. And so especially when we hit that year mark, we really need to be, supporting mom and making sure that she gets everything that she needs for her to be stable and for the child to be successful.
Now, this question, Dr. David, is really for you because it's very, very specific. And the question is, if someone has had 2 myomectomies, but their fibroids have grown back, would you suggest another myomectomy before trying to get pregnant?
That's a great question. And the fact that fibroids affect women of color in extreme numbers it makes it almost kind of our question. The answer to that question, it depends on where the fibroid is, and it depends on the size. When you have a myomectomy is just removal of the fibroid from the uterine tissue, not removing the uterus. So the uterus stays behind, but we're removing these growths. The goal of a myomectomy is to get the fibroids that are causing the problem, whether the problem be pelvic fullness, pelvic pain, heavy vaginal bleeding. Those are the ones that we go for. But you're not necessarily going for all the fibroids, because there may be some that are small. There may be some that are in kind of places that have a lot of blood flow to them. And if they're not that large, it's not worth our patient's life to kind of go after those fibroids. We'll say, you know what, we're gonna get out for now, and we'll see, how this one grows, and it may not. Now, if you had 2, that means you've had this abdominal procedure or laparoscopic through a camera procedure multiple times. And it is important to consider, what the next surgery will look like in terms of the goals of the surgery. So say, for instance, the fibroid is now inside of the uterus. So I think about a uterus like a box, and the fibroid is inside of the box. That's typically where it's going to cause a pregnancy problem, because the baby and the fibroid fighting for space. So those are typically some of the fibroids that we would absolutely go for if we're planning on pregnancy. There are also fibroids that are in the muscle of the uterus that may also be impinging on that inside of the box by their size, causing you to have pain. And those are the ones that we potentially would go for. But if they're not bothering the cavity, a lot of times we don't really even, especially on the 3rd myomectomy, we may not even go for them if they're not very large or causing you a major problem. If the inside of your cavity is okay and clear, then you can still get pregnant and not potentially need a myomectomy. Now, if you have the caveat of a larger fibroid, you're in pain, you're having heavy bleeding, it's inside, and you need to have a myomectomy, then have the myomectomy, but then get pregnant at about 6 to 8 months. Don't wait too long, because like I started with, if you have very small fibroids that we are not operating on, you give them time to grow, you're back in the same position. So you want to remove the fibroids that are going to cause the problem, or that will help clear the cavity so you can get pregnant. Wait the 6 max 8, but minimum 6 months
Mhm.
to kind of heal and then get pregnant.
Thank you. Thank you for that. And actually, I'm going to come right back to Brother Perkins. I have a follow-up to the thorough response you gave earlier. What would be the role of men in the family planning discussion in that conversation? I know you had mentioned about sitting down and having that conversation of planning things out. So what should be the role of the men or the partner in that conversation?
It's of my strong belief that, you know, if if we're family, I'm not like every situation is different. There's no one size fits all. But if we're a family, we're sitting down together. Whether we're together, whether we're still romantically involved, or not, we're sitting down together and we're figuring out what are the next steps of this process for us. What is it going to look like? I deal with so many different situations where mother and dad are living in the same house, situations where mother and dad are living in same state, different states, right? So being able to sit down and draft a plan, hopefully with the family counselor, is going to go a long way to the success of the family, to a long way to the success of mom, a long way to the success of the child. Again, there's necessarily no one size fits all, but the development, the draft of that plan in terms of dad also having a say in necessarily what's going on, I think is extremely important, because I think one thing that we take for granted is that fathers, listen, we all know the statistics in terms of father involvement in their children's lives, right? Especially men of color, for several different reasons, right? But when they are also having a child too, right? So it's going to affect them as well. So making sure that the whole family is getting that support is going to be important in that aspect.
Thank you for that. Thank you for that response. So in the time that we do have left, and I know the time has been going pretty quickly here, but in time we have left, I want to kind of go around the room here to each of you to provide us with a key takeaway or a resource that can assist our audience with the whole idea of Black maternal and mental health. But for my ladies from Sigma Gamma Rho, if you can speak a little bit more about the Project Cradle Care, Project Cradle Care, please do so. And we can start anywhere.
May I start?
Yep.
So a key takeaway for me, and a key message that I just want to leave everyone with, there are huge, and I kind of mentioned it before, there are so many different stigmas for us, right? Black and brown people in terms of seeking help. So one thing I just want to leave everyone with is get help, right? Lean on the support of your loved ones, lean on the support of your friends, lean on the support of all the resources around us. Resources are available. The access in comparison into other populations is not where it should be, but we have to, it's a little bit harder for us, yes, but we have to do the work and find the resources. Getting help is not a sign of weakness, it's a sign of self-awareness, resilience, and a willingness to take charge of your well-being, a willingness to ensure that you and your family are going to be successful. There's no shame in asking for help. It's actually the smart and courageous thing to do, and the better step towards your future.
Thank you. Thank you. Brother Booker?
I would say the two things I would leave you with is family dynamics are very different from this generation, from previous generations. In previous generations, families lived close to one another. People didn't branch out across the country or across the world. You stayed in relative geography. So if you grew up in a place, I grew up in Philadelphia, my grandmother, my great-grandmother, my mother, everyone's within about 10 to 15 minutes of one another. Families did not branch out quite as far. So we live in an era that's very different, where people do expand far and wide. And so that support system is not so readily available at times. The other thing that we have is the internet. So I always tell parents, listen, you do realize generations ago, people raised kids. They didn't have the internet. They didn't have 15 books. They weren't looking all over the place for different sets of information. What they utilized were the people that they trusted the most, because those people already had experience raising kids. And from generation to generation, we take some things from the past, we move and add some things to the future from the present. I find that from a mental health standpoint, the internet creates a lot of problems because people are reading and looking for perfect answers to things they're looking for targeted answers for things that are much more broad. And so you end up putting yourself in a situation where you're creating stress to some degree unnecessarily. Healthcare, medicine is a really difficult thing on the internet because if I'm trying to figure out how to change a filter in my washing machine or my refrigerator, well, there's only one way to do it. In medicine, everything can be nothing and everything can kill you. Every rash can be something simple like dry skin, or it can be meningitis. Belly pain can be gas, or it could be a ruptured appendix, or an ovarian cyst, or something of that nature. So, I think that from a mental health standpoint, a lot of our families are stressed out all the time because you're constantly reading about the worst possible scenarios. And so I think that space where we say trusting your physician or building a relationship that you can have trust. And for us, it's the physicians understanding what people's concerns and fears are, allows us to really directly address those things and either put people at ease or give them the proper ability to further evaluate problems or give them the proper resource to look at, so that they're not constantly in this space of creating worry unnecessarily. But it's really important. Mothers and fathers are, I would say are different. And I recognize that couples come and parents come in different shapes and sizes. Fathers talk to their friends and their friends check in and go, hey, how you doing? How's the baby? How's how's your spouse's significant other? But your conversation will generally go back to your normal conversation. Whereas birthing people and mothers are in a situation where their conversation centers completely around the child and parenting and mothering and the different aspects of that. And so to all the birthing people and mothers, I would say is find a close circle of people that you can talk to, but understand you're going to get advice from everybody, warranted or unwarranted. So when you're getting it too much, people just say to people, thank you so much for the advice. If I have questions or concerns, I know you're present, I know you're available, and I'll reach out to you directly so that every conversation you have is not centered around a healthcare or maternal issue that maybe you were feeling perfectly fine about before the conversation started.
Thank you. Dr. David? Ms. Franklin, go ahead.
Well, takeaway, and then I'll share about Project Cradle Care. The takeaway, and this is something that I always share, whether I'm on a panel or doing a workshop or even in my social media spaces. And I know it's not always accessible, but I always recommend and advocate for Black women, whether they are in their reproductive years or not, to seek healthcare providers that look like them, that come from their communities. There is tons of research that talks about how our maternal health and reproductive health outcomes improve drastically when our healthcare providers are members of our community and they look like us. Just think about meeting that cousin for the first time and you automatically have a bond with them. You speak the same language, right? You may even eat the same foods. You feel comfortable with one another because of the connection and the bond that we have as Black people. I know it's not always possible, especially when you have to receive some sort of specialized medical care or maternal health support, perinatal care. But whenever possible, try to find your Dr. Davids, your Dr. Bookers to care for you and to care for your children. Your outcomes will be better. As far as Project Cradle Care goes, it's a collaboration with March of Dimes, and it's really about raising awareness for the maternal health issues that plague Black communities. So workshops, initiatives, programs, resources, providing this information to communities to help improve our maternal and infant health outcomes.
Thank you. Thank you. Dr. David?
Go ahead, Sorora. As far as my takeaway, I think that we had some great takeaway points. And the one thing that I would add onto that is I tell my patients, there is no stupid question. And I find that people, even though they may see a doctor that looks like them, they are a little intimidated that, we're the doctor, and I don't want to look stupid in front of the doctor, so I'm not going to ask. I tell people all the time, it doesn't matter whether you're my patient or not. I'm here to answer your questions. I went to school to make it into English. So you don't have to go through and read all these things that don't make sense to you. You don't have to go through a million websites and go through a million Googles. Like, I cannot stand Dr. Google because it's not giving you information that you can digest and understand. So that's what I'm here for. Ask me. Do not feel intimidated by the knowledge that I have, because the knowledge is for you. It's not for me to keep inside myself. It's for me to share it with you. So my largest takeaway to our audience, to everyone listening, watching, and those who will listen and watch later, ask your doctor, ask your healthcare provider, ask. Don't be afraid. There is no judgment in our time together. Please ask us. And if you're feeling anything, say something. Don't hold it in. Don't write it off. Don't, I'm short of breath, but I've been short of breath for 3 weeks. So it's probably nothing. Say something, because that little nothing may be something. And if you told me 3 weeks ago, I might have been able to get on top of this sooner than we may be able to do it now. So there's no judgment. There's no fear or intimidation. And if you are in a practice or in a clinic or in an office with a provider that makes you feel that way, run, because that is not what we're here for. We are supposed to make you feel comfortable. We are supposed to make non-English jargon into English so that you can then explain it to someone else who may be experiencing that, who may be uncomfortable asking their doctor. So please, that's what we're here for.
Thank you for that. Thank you for that. And thank all of you for that. And just for our listeners and our viewers out there, just to also give you a little clarification to remind you, the Brothers for Mothers initiatives by Kappa Alpha Psi is designed not only to bring you important information like this and to advocate for the mothers in our communities, but to also provide an outlet and resource for the men in our communities, provide them a place or let them know what their place is in the childbirthing process. So we have that dual role through the Mothers for Brothers initiative. Well, that's all the time that we do have for tonight. I would like to once again thank our panelists, Dr. Allison David, Dr. Larnie Booker, Asia Moosin Franklin, Majesty Perkins, and of course our Assemblyman Brian Cunningham for helping to enlighten us about the disparities in Black maternal health and what we can all do to support Black mothers and their families. Once again, my name is Kevin Boston Hill, and on behalf of the Brooklyn, Long Island Alumni Chapter of Kappa Alpha Psi Fraternity, in partnership with the Eta Nu Sigma Alumni Chapter of Sigma Gamma Rho Sorority Incorporated, thank you all for tuning in to the latest installment of the virtual Fireside Chat Real Talk series, Beyond Birth, a workshop on holistic support for mothers and families. Please